Very nice presentation. This is Dr. Shi again, and I'd like to invite the discussant, Dr. Yanfan Su from the University of Washington, and to give about a 10 minutes kind of comments on this presentation and the contents of this study. Yanfan, are you ready? Go ahead.
Thank you, Dr. Shi. I really enjoy the work done by the team in University of Michigan. And can you hear my voice and see my screen?
Yes.
Okay.
Beautiful.
That's good. One sec. I think currently there is some technical problem. Okay. First of all, thank you again for all of 4 presenters. That's a really like extensive effort to predict the COVID-19 pandemic in India. And for me myself, while I was consulting for the Gates Foundation, I had some hands-on experience with India, and I have done some of the tuberculosis control work in India as well. And that's why I understand the importance of the current study and want to comment on it. So within 10 minutes, I want to cover those 5 aspects in terms of the importance of this study, scientific rigor, policy impact, media coverage, as well as illustrating this as like a successful example from preprints to peer-reviewed manuscript. So definitely India is one of the like largest and most diverse countries for all of us who study global health. And it's very unique opportunity once the country decided to lock down. And that's why as researchers, it's also like extraordinary opportunity for us to both do estimation as well as prediction. For example, in the presentation, we heard that like for Delhi, that's the successful example to reduce R0 below 1. And we also see the challenge in the slum in Mumbai, where maybe there are around 1,000 people share the same restroom. And that's why, like for India, it's very, very challenging to really do good work in terms of prediction, both for the country average as well as the diversified state situation. And we all understand from the presentation that in the study by the team at University of Michigan, they use the SIR model. And here I also summarize other like 5 very popular and well-received models in the United States. And for the majority of them, they all use the SIR, which is quite similar as SEIR model. And then in terms of the duration of their prediction, so for example, for the IHME, which stands for the Institute of Health Metrics and Evaluation at the University of Washington. So for us, our prediction range is 12 weeks. And the same for Dr. Gu's model. And for MIT model, the duration is much shorter, just for 6 weeks. And then for the UK model, they use the duration as 12 weeks as well. And then the only model exception is the LA NL, their model. So they use the dynamic growth model and for short-term prediction. And then if you are interested in understanding more about their model as well as data, I also list the link here for your access. It's frozen again. One sec. So since I worked for IHME last year, and then here I also want to synthesize the strengths as well as the limitations in the IHME model for comparison. So for IHME, it's one of the early starter in prediction of COVID-19 starting from early February. And currently it's covered almost all of the countries over the world. And IHME, they do have the prediction for India, but currently it's not released on the website yet. And then IHME also provided a subnational projections for 8 countries. It's very interesting that, like for the IHME model, actually they are currently taking into account of the variation in age structure, which is really a key driver for all age mortality. And they also keep the system very dynamic in order to accommodate new information demands. So early, like in February and March, there was almost like daily updates, and then shifted towards weekly updates. And I'm amazed by the University of Michigan team that currently you have the most current data for India, almost a daily update. And then in my understanding, like for all the model I mentioned in my previous slide, including the University of Michigan model, it's first wave estimation of the pandemic. I think that's one of the limitations for most of the model currently we are aware of. And then for IHME model, they use observed pandemic curves for COVID-19 death in the countries such as Korea, China, and the United States for estimation and prediction. And then we also have the challenge regarding the accuracy of a reported death attributable to COVID-19. Hopefully, over time, we will have more high quality data. And then like for the IHME prediction, like there's also the quantification of the potential gap in physical resources and try to estimate the peak of the health system. But I think there's even like larger potential gap in terms of the human resources, lack of physicians, nurses, and also currently there's lack of measure of healthcare quality. For example, for the death toll in Italy, there was a study regarding like the lack of high quality healthcare due to the peak of the COVID-19 cases. That was one of the factors for the total death toll in Italy. So for IHME, currently they are also considering other covariates in the prediction model I listed here. Somehow my computer is very slow today. As the presenters mentioned that I really like the feature of having the dashboard for policymakers. Since I had been working on policymaking for almost 4 years, I understand that like for us, we really emphasize of scientific rigor, but certain times or scenarios, it's very, very difficult for policymakers to understand, digest, and really have the information to inform their decision making. So I think besides the scientific rigor, the University of Michigan team also did a fantastic job regarding synthesizing the information and visualizing in such way, very easy for the policymaker to use. And then here I also want to highlight that actually on July 20th, there was the opinion published in the New York Times in which 2 of the scholars from California, I think like one from the University of UC Berkeley and another one is from Stanford. And they make a very important point regarding preprint, which we also like discuss a bit regarding the pros and cons, because on one hand, we really have the like real-time data as well as like the research concept and the preliminary results from preprints. But the shortcoming is that actually there is no peer review process. And then for the journalists, they don't have good understanding about the standards of preprint. And then they always take the conclusions as conclusive as they think it could be, and conveying to the public, which might be misleading. But I think like for the opinion published in the New York Times, they do mention the study by the University of Michigan team as a very successful case of a preprint, and also congrats that it will be published by the Harvard Data Science Review. And if we have any takeaway or think about next steps from this study, so if we take a look at the RT, currently is still greater than 1, that make us ask the question like, what can we do to help India in the next steps? And it's very interesting that for the colleagues who published a paper as a NBER working paper, they do mention an alternative step as the adaptive control of COVID-19 outbreaks, in which they proposed the exit plans, which is very localized, it's very gradual, and also it's triggered based upon the public health information in the local areas, such as in the state or in the slum. So they do have the prediction for 4 states in India, and we'll see that like for the solid black line, that's the empirical case data, and then the blue line, that's the lockdown until early May, and then like the yellow line is the lockdown until late May. Interestingly, if we think about the alternative, like the adaptive control process, and if it's measured by number of infections in the y-axis, and we see that it looks like a very good performer. And I want to highlight that in this paper, they use the same model as the University of Michigan team did. So I think those are the major points I want to share. And then if you are interested in the working paper, here is the citation. And then I also feel like very happy to review the COVID-19 site prepared by the Michigan team. Especially, I encourage you to read their trilogy. It's a kind of interesting story which they draw in the pre-lockdown term and within lockdown, as well as kind of thinking about unlocking the lockdown. So it's fantastic work. Thank you. Oh, Dr. Zhi, you are muted. We cannot hear you now.
Sorry. Hey, I'm so sorry. I just thank you, Yan-Fan, for your discussions and then make key points. I know that we only have like 1 hour left, and then we're supposed to move into the next calls. But I just reading the chat room. There's one clarification questions which on the slides number 31. Okay, so actually I have the same question. Why these normal slide number 31? Yan-Fan, would you mind?
I will stop share.
Dr. Mukherjee, do you mind that, this last slide, 31? Well, 31 basically, with why the normal is lower than the travel ban plus social distance in the, I think it's a right-hand side of your plot. So basically it's kind of tricky. So that's a 31. If you can find your slide number 31, if you look at compare the normal and then the travel ban plus the social distancing. And then
We're muted.
I can hear you, yes. Go ahead.
So can you see my slides now?
Yeah.
Okay. So this is the slide you're talking about.
Yes. 31. That's 31. Yeah. Yes. So
yeah, go ahead.
So the normal and then the social distance plus travel ban, the yellow and basically the green, those are the shape. There's one obviously is, yeah.
Yeah, so the couple of things. One is that somebody else asked, what does it mean to be cautious returns? What does it mean to be moderate return? So what we assumed is that after the lockdown, what would be the conjectured values of R? And so we basically set in here the R after the lockdown. We sort of anticipated that the whole of India is not going to come down below 1. And probably that's why our modeling projections have been so accurate, because we actually did 1.2 and 1.5 as our hypothetical values of R, and that was back in April. And it so turned out that throughout June and July, the India R has been at 1.25 and 1.3, right in the middle of these two scenarios that we had conjectured, right? So this is basically, as if you do simulation study, you think that you understand that this is pure guesswork. And why do these two lines cross? That's an interesting story, because so social distancing and travel ban. So basically, this is without lockdown. So we feel like this is continuously, like, sustained, gradual, modulated intervention is continuing. And there we feel that this is like 1.5 throughout. Whereas this one actually has a lockdown for 21 days, but then resumption of activities so that the R goes back up to 2. So the effect of that is negated if you really get back together and forget about any kind of non-pharmaceutical intervention and resume normalcy. So that's why the curves actually cross. It's a little counterintuitive, but it's about what is the pattern of R's that you've assumed throughout the course of the intervention.
Okay, thank you for clarification. And then we need to move to the next talk. Do you mind stop sharing so that we can